morning, everyone, and good evening to those of us watching this recording later on. My name is Alexandra. Thank you so much for joining me for another session for our NCLEX review. Today, we are going to review what we learned last week about heart blocks and continue on as we move towards finishing cardiac. Let's go ahead and open up with a word of prayer. Our dear Heavenly Father, thank you so much for my students. I pray that you would bless them, help them, Lord, to pass their NCLEX. In Jesus' name, amen. All right, so just a little review about what we learned last week. Remember, you have to understand EKG paper time. Remember, we talked about 5 of these boxes equals 1 second. 1, 2, 3, 4, 5. And so 30 boxes equals 6 seconds. We also added 2 new numbers for you to memorize. So let's look at the next picture. So we've already said that 5 of these boxes makes 1 second, right? So that means each of these boxes is 0.2 seconds. And you also have to know that each one of these small boxes is 0.04 seconds. Okay, so I know that's a lot, but worst comes to worst, memorize what's in yellow. Okay, that 5 of these boxes, 1, 2, 3, 4, 5, is 1 second. And these little boxes are 0.04 seconds. We did a review of the EKG waveform, the morphology of it. You've got your P wave, and then you've got your QRS and your T. Your P represents atrial depolarization. The QRS represents ventricular depolarization. The T wave represents ventricular repolarization. Then we learned about the different times and certain variables or characteristics used to describe the heart's activity, like an interval or a segment. And we said for NCLEX, the 2 most important ones to memorize are the PR interval and the ST segment. So we said that for the PR interval, it's very important to memorize the time. The PR interval should be 0.12 to 0.20 seconds in duration. And the PR interval, it's going to tell you how long does it take for the atria to contract to right before the ventricles contract. So it's going to tell you about the electrical conduction functioning of the heart, because it's going to tell you how long does it take for the signal to originate in the SA node, which would then make the atria contract, until it gets to the AV node. It tells you how well are the atria communicating with the ventricles. And so make sure you memorize normal PR interval 0.12 to 0.20. And also make sure you know that once we start having delays in certain patterns, this is what we call heart blocks. Okay. Another important characteristic we learned about the EKG waveform is the ST segment. And remembering that what's important for ST segment is the shape of it. It should be iso, or the appearance of it. It should be isoelectric. It should be flat. We learned that ST segment depression indicates ischemia or hypoxia. ST elevation indicates infarction, like a heart attack. We also learned there's 2 different types of heart attack. If someone has a heart attack and their ST segment is elevated, that's called a STEMI, an ST elevation MI. Or if they don't have elevation or they have depression of the ST segment, that's called an NSTEMI, a non-ST segment elevation MI. So we've talked about this already. The PR interval, it describes the relationship between the atria and the ventricles, how they're communicating through the electrical conduction system. And we learned about this when we first started cardiac, so you're good with this already. So make sure you memorize that for NCLEX. Honestly, the chances of you getting heart blocks on the NCLEX are very low. I truly believe that. I believe, you know, I think you have less than a 20-25% chance of seeing it on the NCLEX. But if you do, it's going to be one or two things they're going to want you to know. One, they're going to want to know, do you know the normal time of a normal PR interval? And are you able to count the little squares to see that there's a delay? Or the question could come at the angle of wanting to know that, do you know that you treat heart blocks like symptomatic bradycardia? So the same treatment algorithm that you use to treat symptomatic bradycardia, atropine, transcutaneous pacing, transvenous pacing, pacemaker insertion, that same treatment that I just said, if you can memorize that, that's how we treat heart blocks, then you will be okay. Okay, give me one moment. Someone's having some trouble. So, all right, so let's do a little refresher. We did this last week, but I just want, to help reinforce your understanding of this. So, can someone tell me, or can everyone tell me in the chat, what is this PR interval in seconds? And is it normal or is there a delay? Very good. And just tell me the seconds in the chat. I just want to make sure you can count it, can count the boxes. Very good, very good. So only two people answered, right? Okay, so the more that you answer, the more I will know that you understand it. Okay, so very good. So this PR interval is 3 boxes. Very good. So let's see, how did we get to that conclusion? So remember, the PR interval is from the beginning of the P wave to the beginning of the QRS, right? So from the beginning of the P wave to the beginning of the QRS. So that's how we get our 1, 2, oh, hold on. Our 1, 2, and 3, okay? And it's the same here, or it's just 1, 2, and 3. So from the beginning of the P wave here, let me see if I can make this a little thicker. So it goes from the beginning of the P wave to the beginning, right when it dips down, okay? And then of course, as we get, into more EKGs, things get a little more difficult to count. However, I think you would get something very simple if you even got it on the NCLEX. So heart blocks are called AV blocks as well. So if you see AV block or prolonged PR interval, it's all the same. Just making sure you know that 3rd-degree heart block is the most serious. It is a medical emergency. This patient should be in ICU. Okay. So first up, we have 1st-degree AV block. 1st-degree AV block, the PR intervals are constantly prolonged, greater than 0.20 seconds. So Remember, if each box is 0.04 seconds, how many little boxes is the PR interval always going to be greater than? It's always going to be greater than 5, right? Because 5 times 0.04 is 0.20. So a first degree AV block, it's always too long. The PR interval is always going to be greater than 5 boxes. Does that make sense? And you have to put the answer in the chat so that, okay, thank you. Okay, so, and even just looking at the EKG waveform, even just looking at it, you can see that the PR interval is too long, right? Just look at that EKG and you kind of are looking at it and you're like, it doesn't look normal, but you would count it, okay? So I want everyone to count. Let me see if I can make this a little bigger. I want everyone to count the PR interval. Oh, hold on. Okay, I'm trying to make it a little bigger, but it won't. So tell me, what is the PR interval for this EKG? So remember, it goes from the beginning of the P wave. That's a little too thick. One moment. From the beginning of the P wave to right when it dips down to the beginning of the QRS, right? So let me get, so that's 1, 2, 3, 4, 5, 6, 7. You could say 7.5, okay? But either way, and if you were to count all of these, you would see it's all 7.5, 8. And so you would see, because it's always the same and it's always delayed, that is what we call first degree AV block. So write that down. If it's always the same and it's always delayed in terms of PR interval, the duration, it's first degree AV block. Okay? So if it's always 6 boxes for the PR interval, or if it's always 7, always 8, it's always too much and it's always the same, that's first degree AV block. Next up is second degree AV block type 1. And they also call it Mobitz 1 or Winky-Bach. Okay? So how many eyes do you need to wink with? How many eyes do you need to wink with? You only need one eye to wink, right? So that's why I can remember in my head when I see Winky-Bach, I'm like, oh, that's Mobitz 1 or that's second degree AV block type 1 because you only need one eye to blink with. Okay, so in second degree AV block type 1, the PR intervals get longer and longer until it drops. So that's what they say, longer, longer, longer drop, Winky-Bach. So that means the PR intervals are going to be longer than 5 boxes. And then eventually you're going to lose a QRS. So I want you for each of the heartbeats you see, because you see 4 heartbeats here, right? It was supposed to be 5, but for something strange happened. For each heartbeat, I want you to count the PR interval or tell me the PR interval duration, and then we're going to come back together and figure it out together. As a short reminder, just another few moments, you're supposed to be counting the PR interval for each of the heartbeats you see and put your answers in the chat.
So you know the usual, we're going to start out with some coconut oil, and then we're going to follow that up with a nice handful of pimento seed. Now we're going with some hot pepper, red onion, scallion, thyme, bunch of garlic. Now we're going with 2 red pepper. We are going with a bunch of...
Oh my gosh, I'm so sorry if you heard that. That was an accident. Okay, so, all right, so let's count this one together so we can see what's going on here. So remember, the PR interval is from the beginning of the P wave to the beginning of the QRS, okay? From the beginning of the P wave to the beginning of the QRS. Okay, so let's count this first one. 1, 2, 3, 4. Is there anything wrong with the first one? 4 boxes. No, right? There's nothing wrong with the first one. The first one, 4 times 0.04, that's 0.16 seconds, right? There's nothing wrong with that. Okay, then the second one, 1, 2, 3, 4, 5, 6. So right away you know something's wrong because it's greater than 5, right? Because a normal PR interval should be 3 to 5 boxes long. And so 6 times 0.04, so this is 0.24 seconds. And so that's when you, just from this progression alone, to go from 4 to 6, already you know there's some type of issue. So let's count the other one, the third heartbeat, because remember, a full heartbeat is the P, the QRS, and the T, right? So here's the third heartbeat. 1, 2, 3, 4, 5, 6, 7. You could say 7.5 or 8, right? It's either way, 7.5 or 8, you're fine, okay? So what is that in PR interval time? So all you have to do is on your phone, put 7.5 and multiply by 0.04 and you get, oh my gosh, 30 seconds. Okay, so definitely it's taking longer and longer for the atria to communicate with the ventricles. And then what happens here, what do you think happened here in the fourth heartbeat? Or the alleged heartbeat, because I just circled it. You've got the P wave, but what's missing? The QRS and the T, right? So you're like, wait, and what does the P wave represent? The P wave represents when the atria contract, right? And the QRS represents when the ventricles contract, and then the T wave represents when the ventricles relax. So the fact that the QRS and the T wave are missing, that means all ventricular activity is not represented. It's not represented at all in this heartbeat. It's not a heartbeat, but You see what I'm saying? So only atrial activity has occurred because only the P wave got transmitted onto the EKG. So there was no ventricular activity at that point in time where there should have been. So what do you think that means about the communication between the atria and the ventricles if only you see atrial activity? The QRS and the T wave are gone. What do you think happened with the communication? It got blocked. There you go. Or it dropped, right? Sometimes they say blocked or dropped, right? So here they call it drop, right? The PR intervals get longer and longer and longer until there's no PR interval. You can't calculate the PR interval because there's no QRS, right? So that's why they say second degree AV block type 1 or Mobitz 1, the PR intervals get longer and longer until it drops and then it restarts again, right? So let's count the fourth heartbeat. So 1, 2, 3, 4, 4.5. So it went back to normal because it's less than 5 boxes. And then, the one after that is going to be a little longer. Then the one after that is going to be a little longer. And then next thing you know, the QRS is going to drop again. So longer, longer, longer drop, Winky Bach. Second degree AV block type 1. Any questions so far? Is everyone okay? Okay, and remember, this is recorded, so you can always go back, okay? Next up is second degree AV block type 2. So write this down. So far in your notes, you should have that first degree AV block, that the PR intervals are always long, or they're always too long, but they're always the same, right? First degree AV block, the PR intervals are always too long, but they are always the same. Second degree AV block type 1, which we just saw, that's the longer, longer, longer drop, Winky Bach. Then you have second degree AV block type 2 or Mobitz 2, where it's kind of a mix of type 1 and second degree type 1. It's a mix because the PR intervals, they stay the same being too long, and then out of nowhere the QRS drops. So I'm going to give you a moment. Let you write that down, and then I'm going to ask you a question to check your understanding. Okay? So make sure you wrote down first degree AV block. It's always too long, but it's always exactly the same. So if it's 6 seconds, each one is 6 seconds. There's, no QRSs are missing or nothing like that. Second degree AV block type 1, that's where you get longer, 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 and then drop. You're missing a QRS. But the PR intervals get longer before it drops. Second degree type 2, they stay the same length, 6 boxes, 6 boxes, 6 boxes, QRS drops. 6 boxes, 6 boxes, 6 boxes, QRS drops. So let me give you a moment to let that marinate, and then I want to ask you a question. All right. So tell me yes in the chat if you've written your notes for first degree heart block and second degree heart block type 1 and second degree heart block type 2. Put a yes in the chat if you've written it down in your notes. All right, perfect. So I want you to tell me what is the difference between second degree AV block type 1 and second degree AV block type 2? What is the main difference? And if you can answer that, you're good. You're ready for any kind of question like that on the NCLEX. Come on, guys, quickly, 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 so we can keep moving. All right, very good. So the main difference between type 1 and type 2 of second degree heart block is type 1, the PR intervals are getting longer before it drops. But second degree type 2, they stay the same. They're still too long, but they stay the same each time and then it drops. Okay? Exactly. Longer, so second degree type 1, it's getting longer and longer over time, right? Mm-hmm. Finally, we have third degree AV block. So third degree AV block is always very confusing. It's always very, very confusing to identify for me. Okay, not for everyone else, but for me. What has helped me is to count the P waves, and then you'll see that there's more P's than there are QRS's. And that for some reason helps me to identify it. So the problem here is there is a complete lack of communication between the atria and the ventricles. There's no conduction between them. The P's are regular. The QRS's are regular. They just don't happen together. So look at the first P wave. And this is crazy. I want calculate the first PR interval. Oh my gosh. It's so scary when you count it. Calculate the first PR interval. So how do you do that? Remember, your PR interval, let me do this in yellow so it's a little easier to see. Remember, your PR interval is from the beginning. Nope, not big enough. Or bright enough. Let me see. Your PR interval is from the beginning of the P wave to the beginning of the QRS. So now we have to count these boxes. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Lord help us. That's horrible. Okay, so 14 boxes. Okay, and so in your calculator, multiply 14 times 0.04. Oh my gosh, 56 seconds. That's crazy, right? Because a normal PR interval should be 0.12 to 0.20 seconds long. This is like more than double what it should be. And then also what helps is just count the P waves. 1, 2, 3, 4, 5, 6. I will count the P waves, and then you see that there's 6 P waves and 3 QRSs. So when in doubt, count the P waves, and if it's more P waves than QRSs and the PR interval is just very, very delayed, it's third degree heart block. Remember, third degree heart block is a medical emergency. All right, now calculate this PR interval for me. So as you can see here, can you really count the PR interval from the first P? No, because it's missing a QRS. So that's going to be your first key in figuring out, okay, maybe this is some type of heart block. And then when you count the P waves, 1, 2, so 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. You have 11 P waves and only 4 QRSs. That's when you're going to say, you know what, this is probably third degree heart block. When the Q's and P's don't, when the P's and Q's don't agree, you think third degree. So I have a little picture that will help you. But first, let's talk about symptoms and management. So the symptoms of heart block are going to be bradycardia, a low heart rate. Make sure you memorize these 3 for your NCLEX. Symptoms of heart block: bradycardia, dizziness, and fainting. So heart block is going to decrease the heart rate. Okay. So for first degree heart block, remember this is the one where it's always too long, but they're always the same. A majority of cases of first degree heart block require no treatment. The cardiology may consider a pacemaker if the PR interval is greater than 0.30 seconds with symptoms. Then we have second degree AV block type 1. This also often requires no treatment. However, if the patient is symptomatic, atropine, which patients with second degree AV block type 1 tend to respond well to the atropine. If that doesn't work, transcutaneous pacing, transvenous pacing, permanent pacemaker. Second degree type 2, unfortunately, this often does not respond to atropine, and we're going to do immediate transvenous pacing until a permanent pacemaker is inserted. Then we have third degree AV block. This is a medical emergency, and patients tend to not respond well to atropine, so we are going to use that symptomatic bradycardia algorithm for emergency pacemaker insertion. Okay, so those are the heart blocks, and this is a little poem you can use to help you memorize. So if the R is far from the P, then you have first degree. So if it's always the same distance though, and then longer drop, then you have Winkie-Bach. And then if some P's don't get through, then you have Mobitz 2. So Mobitz 2, remember, They're always the same, just too long, and then the QRS drops out of nowhere. And then if the P's and Q's don't agree, you have third degree. That means if you have more P's than Q's, then this is third degree heart block. All right. Okay, guys, so you guys have done wonderful. Let's take a 10-minute break, and when we come back, we're going to do pacemakers, and then we're going to do our EKG quiz. Thank you so much. Okay. So, a pacemaker is a surgically implanted device, and it can have atrial leads, ventricular leads, to do atrial pacing, ventricular pacing, or both. Okay. So, what you have to know for NCLEX is how to recognize. Oh my gosh, you can't see what I'm looking at. I'm sorry. One moment. So this is an example of a pacemaker. Here you have the device and then it has leads, and the leads can go for atrial pacing, ventricular pacing, or it can do both. What you have to be able to recognize for the NCLEX are the spikes. So if you see a straight up and down spike before the P wave, that's atrial pacing. If you see an up and down spike before the QRS, that's ventricular pacing. So let me show you. So this picture is atrial pacing because the spike or the pacemaker spike comes before the P wave. Then we have this example. So I know that this QRS looks a little different than what we're used to. This QRS looks upside down. And that's because there's different leads that you can get an EKG from. And depending on where you get the EKG, what lead you get the EKG from, the QRS might look upside down, but it's okay. We're still looking at the ST segment. We're still looking at how long it takes for the QRS to happen. So based on this picture, is this atrial pacing or ventricular pacing? Please put your answer in the chat. This is ventricular pacing because it comes before the QRS. Very, very good. Okay, and so now if the spike was before the P wave and before the QRS, so let me give you an example. So if it was like this, and like that. So now, if there's a pacemaker spike before the P wave and before the QRS, now that would be both atrial and ventricular pacing. Okay. All right, guys. So what we're going to do now is we are going to do a quiz on your EKGs. So I'm going to give you, go ahead and take 10 minutes to review your EKGs that we've learned all the way from normal sinus rhythm, sinus brady, sinus tachy, AFib, A-flutter, SVT, VTach, VFib, torsades de pointe, your ventricular bigeminy, trigeminy, quadreminy, your asystole, your PEA. Okay, the heart blocks, go review those. I'm going to give you 10 minutes to review, and everyone has to be typing their answers in the chat. If you are new, of course, you can just observe, okay? So go ahead and take 10 minutes so that you can review for your EKG quiz that we're going to take live together. And I will see you back at 11:17. Thank you so much. If you are new, you have the study guide with you. You can just continue on in your reading of Module 5 in the study guide. Thank you. All right, everyone. So we're going to go ahead and get started with the quiz. So remember, put your answers in the chat. If you are at work, I completely understand if you cannot answer. But if you are not at work, please try your best to answer so that I can see how you're understanding it. All right, so first question, is this EKG sinus? And what is the name of this EKG rhythm? Very good. This is a sinus rhythm because there is a P wave in front of every QRS, and the QRSs are always the same distance apart, right? And then when you count the QRSs, you get 1, 2, 3, 4, 5, 6, 7. So the heart rate is 70. Normal sinus rhythm. Very good. Next one, is this a sinus rhythm? And what is the name of the rhythm? Very good. This is sinus bradycardia. So there is a P wave in front of every QRS. The QRSs are all the same distance apart. And you count it 4 QRSs, 4 times 10, the heart rate is 40. So how do we treat bradycardia? Do we treat all bradycardia like the moment the patient has bradycardia, we need to treat it? Or is there one characteristic we're looking for to determine if we have to treat it? Very good. So you only have to treat bradycardia if the patient is symptomatic. Very good. And so what is the name of the drug we would use to treat symptomatic bradycardia? Atropine. Very good. Not magnesium. Atropine. What we use to treat symptomatic bradycardia is atropine. And if atropine is ineffective, what do we do next? Transcutaneous pacing, right? So if atropine is ineffective, then we do transcutaneous pacing. Then if transcutaneous pacing is ineffective, we do transvenous pacing. And the final stop is to have a pacemaker inserted. Okay, next rhythm, is this sinus and what is the heart rate? Very good. So this is a sinus rhythm. There's a P wave in front of every QRS. The QRSs are all the same distance apart, and you count them, and you've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 QRSs. 13 times 10, heart rate is 130. This is sinus tachycardia. So when figuring out how to begin treating this patient, well, first of all, if they even need treatment, right? Because what if they just got done working with physical therapy and their heart rate is in the 130s? Do you need to treat it right away? Or do you want to allow the patient to rest and then you recheck in a few minutes? Right? So everything is about situation and an understanding of the bigger picture. Or what if you just told them some really bad news? The tachycardia could be because of stress. So, different things can cause tachycardia: pain, stress, emotions, shock, anger, right? Um, Now, what if they have tachycardia with a fever? Are you going to think more infection? Exactly, right? So if the patient is tachycardic, that's why we usually, when in doubt, take a set of vitals. And so if you see on the monitor they have tachycardia and you do a set of vitals and you see they have a fever, then you're going to be concerned about maybe sepsis. So that's when you would communicate with the healthcare provider to see if they want to do blood cultures, give some Tylenol for the fever, and some fluids. Now, in addition to when a patient has sinus tachycardia, you have the heart rate. What is the other key component you need to have like a fuller cardiac picture? You have the heart rate. What else do you need so that you can make some proper nursing judgments? Blood pressure, very good. Remember, when you have the heart rate, you also want to have that blood pressure so you can kind of see where the patient is cardiac wise. So if they have a high heart rate and a low blood pressure, what do you think would help the patient? They have a high heart rate and they have a low blood pressure. Very good. What could benefit the patient would be fluids, right? Because the heart rate is probably high because the blood pressure is low. And blood pressure is a reflection of your fluid volume. So the less fluid volume you have inside your blood vessels, the lower your blood pressure. So if we increase the fluid volume by giving IV fluids, we can help improve the blood pressure and normalize the heart rate. Okay, what about if you check the blood pressure and now you see they have a high heart rate and a high blood pressure? What class of medications is very good? Usually, the doctor will order, or healthcare provider may order beta blockers because beta blockers would help to drop both. Okay, but just always make sure for the rest of your nursing career, beta blocker both. Before you give a beta blocker, check both. Even if it's been 5 minutes since the doctor gave you the order, check it right before you give it. Because if any of them are low, blood pressure or heart rate, any of them are low, we can seriously harm the patient. Okay, very good. All right. Yes or no? Is this a sinus rhythm? This is not sinus. It never, ever, would meet those qualifications. Because to be a sinus rhythm, you have to have a P wave in front of every QRS, and all the QRSs have to be the same distance apart. So if you see from the first one to the second one, that's one distance. Then from the second to the third comes a little closer. Then from the third to the fourth comes a little closer. Then from the fourth to the fifth, that's a different distance. So because the distances between the QRSs vary, this is not sinus rhythm. In fact, there's no discernible P waves. What is the name of this rhythm? Very good. This is atrial fibrillation. And you can see that these here, what do we call those? We call those fibrillatory waves, right? We call them fibrillatory waves. So this is AFib, atrial fibrillation. Okay, so what do we call it when the patient has atrial fibrillation but they have a normal heart rate? What do we call it? Very good. We call that atrial fibrillation with a controlled ventricular rate. So now what do we call it when they have atrial fibrillation with a rapid heart rate, like greater than 100? So when a patient has atrial, so you guys need to study these. You're getting a little bit more quiet. That's how I know you need to study that. Okay. So atrial fibrillation, when the heart rate is greater than 100, we call that AFib with RVR, atrial fibrillation with a rapid ventricular response. So what are some medications we use in the treatment of atrial fibrillation? There was three major ones we talked about. Diltiazem, very good. What else? So you see, you need to study. You're going to see this on the end class. Atrial fibrillation is the most common dysrhythmia in the world. What does that mean? If you do an EKG on a patient and the EKG is abnormal, it's most likely AFib. It's the number one dysrhythmia in the world. So you will have questions on AFib. And you guys don't know the answers to the medications, you need to study that better. You have the recordings and you have the book. Okay? So when it's AFib with a rapid heart rate, it's called AFib with RVR. R as in Robert, V as in Victor, R as in Robert. Rapid ventricular response. So the medications used to treat atrial fibrillation that you need to know for NCLEX, diltiazem and beta blockers like metoprolol. Okay, for long-term management, we do warfarin or Coumadin to help prevent blood clots. Very good. Okay. Is this rhythm normal? Is it sinus? Very good. And what is the name of this rhythm? This is a flutter. And remember, though, they look like shark teeth, right? Those F waves, those flutter waves, they look like shark teeth. And I shudder when I see a flutter. Why? Because it looks like shark teeth. That's how I remember it. Okay, very good. This is atrial flutter, and we use the same medications, diltiazem, metoprolol, or a type of beta blocker, long-term management with an anticoagulant like warfarin. And so between AFib and aflutter, which one is more likely to respond to medication? AFib, very good. Atrial fibrillation is more likely to respond to medication. So atrial flutter is usually more resistant to medication. So what is more likely going to be more effective in resolving a flutter? What procedure would they maybe have to do? Do we defibrillate a flutter or do we use cardioversion? Cardioversion, right? Very good. So you can do cardioversion for AFib or a flutter, but AFib is probably going to respond to the medication, right? A flutter is a little bit more resistant to it, and you may have to do cardioversion. Cardioversion, you're delivering a lower amount of energy, like 50 to 200 joules, versus defibrillation is 200 to 360 joules. What's another type of procedure that they can use to help with AFib or a flutter when it's due to one area of the heart that has like irritated heart muscle cells that kind of take over, and the doctor, the cardiologist may need to burn that patch so that it stops causing the dysrhythmia. Ablation, very good. So for AFib, a flutter, just remember diltiazem, a beta blocker like metoprolol, anticoagulation, long-term like warfarin. Um, you can do cardioversion, you can do ablation. And remember, the issue with both atrial fibrillation and atrial flutter is it increases the risk for blood clots and stroke. All right, what is this rhythm? Is it sinus? Yes or no? What is the name of the rhythm? And what is the abnormality you see? So this is 3 questions. Is it sinus? What is the name of the rhythm? And what is the abnormality that you see? Very good. This is sinus rhythm with a PVC. Very good. And then you're going to see that when you hang around a lot of monitor techs and things, they're so good at, their job. And they're going to show you, because how people usually say like normal sinus rhythm. Well, when something is not right with it, but it's still sinus, so a monitor tech, they're not going to call this normal sinus rhythm with a PVC. They're going to call it sinus rhythm with a PVC, because it's not normal because of the PVC, right? So they would say sinus rhythm with a PVC. Very good. And remember, a PVC is a very wide, bizarre QRS complex that just happened before it should have. Okay, so what are you concerned about as a nurse? Are you concerned if you just see like one PVC randomly and then you never see it again? Or when should you become more concerned? Very good. As a nurse, you get concerned when you start to see PVCs more often in your patient. And what should you check if you start to see PVCs? Potassium. Do you think the potassium's too high or too low? Too low. Very good. All right. Is this ventricular trigeminy, bigeminy, or quadgeminy? Very good. This is ventricular bigeminy. So remember, the bi means two. So that means that the PVC is always number two. So normal heartbeat, PVC. Normal heartbeat, PVC. So 1, 2, 1, 2, 1, 2. So because it's always number two, it's bigeminy. What about this one? It says bigeminy, trigeminy, or quadgeminy. Very good. This is trigeminy. So the tri means three, so it means that the PVC is always number three. So the more complicated it gets, usually the first PVC, like the normal heartbeats are cut off. So use the other one. So 1, 2, 3. 1, 2, 3. 1, 2, 3. Because the PVC is always number three, ventricular trigeminy. Very good. And then what about this one? Very good. Ventricular quadgeminy. Quad means four, so the PVC is number four. 1, 2, 3, 4. Very good. All right. How would you describe these PVCs? Would you call them unifocal or multifocal? Unifocal. Why? What about them makes you feel that they're unifocal? They're facing the same direction. Very good. So you can say they're facing the same direction. You can also say they look the same. So because they look the same, they came from the same foci, the same irritated area of the myocardium. So that's a unifocal PVC. Very good. And then how would you describe these PVCs? Excellent, multifocal. So they're facing opposite directions or they're facing different directions. They look different because they came from multiple foci, multiple areas. Different areas of irritated cardiac muscle cells produced this. Okay, that's why it looks like that. Sure, Miss Frislane. Okay, so unifocal basically means they look the same, they're facing the same direction because they came from the same irritated part of the heart, right? Multifocal, they look different. So let me circle, let me see if the arrows are going to show up. Two arrows are supposed to show up. Nope. Okay, hold on. Let me circle them for you. So this is the first PVC and this is the second. So they look different. They're facing different directions because they came from different areas of the heart that are irritated. Okay? So this quiz is very good because remember, we've went through this already. So if you have questions, of course, I'm here to answer them for you. That's why I'm here. But I want you to review them so that you can be very strong when you go on the NCLEX. Cardiac, you have to be your most strong in cardiac. Okay? Is this a sinus rhythm? Very good. Absolutely not. No, 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 right? There's no P waves. Okay. I don't see any P waves. This you're gonna laugh, but these are all PVCs. So what do we call this rhythm? Ventricular tachycardia, right? Because didn't we say three PVCs in a row constitutes ventricular tachycardia. So VTach is just all PVCs, right? And what is your number one priority when your patient has VTach that you've confirmed is real? Very good. Number one priority. If you memorize this, this will take you very far for NCLEX. Number one priority for VTach is to check if the patient has a pulse. If your patient has VTach with a pulse, what do we do? Amiodarone. Very good. If your patient has VTach with no pulse, what do we call that? Very good. So when your patient has VTach without a pulse, we call that pulseless VTach. And so what is the number one treatment that we need? How do we treat this to bring this patient back to life? Defibrillation. So very good. So remember for your NCLEX and for your nursing career, ventricular tachycardia, you have to know what it looks like. And there's two types. So is this monomorphic VTach or polymorphic VTach? This is monomorphic because it looks all the same, right? They're not like really big and then really small and then very good. So for NCLEX, you have to know VTach, your number one priority is to check for a pulse. If they do have a pulse, amiodarone, because it's going to decrease the dysrhythmia. If they do not have a pulse, we call that pulseless VTach, and we have to defibrillate as soon as possible. Now, is the defibrillator usually in the room with you? It's usually not in the room, right? Unless the patient was like circling the drain for like a couple hours and you were really nervous and you kept the crash cart right by the door, right? But usually the defibrillator is not in the room, even though the only way to treat pulseless VTach is with defibrillation. Is it appropriate to do CPR on the patient while someone else go gets the defibrillator? Very good. Yes. So that's what's expected of you as a nurse, that you are going to be delivering high quality, well, that you're going to go in the room, you're going to say, hey, the patient has no pulse, they're not breathing, and you call code blue, you do CPR. When the defibrillator gets there, we turn it on, we put the pads on the patient, high, right, low, left, we plug the leads in, and then we say, nobody touch the patient, and you see the VTach on the monitor, and then you say we need to defibrillate. So even while you're waiting for the defibrillator to charge, because when you press it, it needs a few minutes to charge, somebody still needs to be delivering high quality CPR right up until someone says clear, delivers the shock, and then we're going to resume CPR for 2 minutes, and then in 2 minutes we're going to do a pulse and rhythm check. Remember, whenever we're doing rhythm check or pulse check, do you want someone touching the patient? No, right? Because if somebody is moving the patient or touching, it can make it look like VFib, it can make it look like VTach, um, and that can cause us to shock the patient inappropriately, right? So very good. All right, what is this rhythm? Is this sinus? No, right? Very good. And then so what is this called? VFib, very good. And the number one priority for VFib? Number one treatment for VFib, you defib, right? Very good. And remember, it's expected of you that while right up until the defibrillator is there on charged and ready to send that shock, that we are performing high quality CPR. But just keep in mind, the longer we wait to defibrillate the patient, every minute that goes by that we do not defibrillate VFib or pulseless VTAC, the patient loses 10% chance of coming back to life. Remember, remember. VFib and pulseless VTAC are the patient is dead. When they have those rhythms, they are dead. And if you do not defibrillate them, they will stay dead. Okay? Remember, delivering high quality CPR will result in minimal to no loss of brain function. That's how you know CPR was high quality and effective. Okay? The goal of CPR is to oxygenate the brain and vital organs. The goal of CPR is to allow for us to identify the rhythm to determine if it's shockable or not. So that if it's shockable, we shock them. If it's not, we can continue figuring out what has caused this patient to be coding right now. What do we use to figure out why the patient is coding? We use it's a group of letters. What's the letters we use to as we're doing CPR and we're like, why is this patient coding right now? We use the H's and the T's, right? Yes or no? Okay. So what about if you're taking care of a patient, you come in the room, they're not breathing, they don't have a pulse, you call code blue, you start CPR, we get the defibrillator in there, we hook them up to the monitor, they don't have a shockable rhythm, so we resume CPR. Can we keep doing CPR for 5 hours? Or do we need to figure out what could have caused this? So what if you're like, you remember, and as you guys are discussing as a team, as you're doing CPR, what could have caused this? And you're like, well, she is a diabetic and she missed breakfast this morning. Do you think, like, while you're doing compression, someone's doing airway, that someone else who's not doing something can check her blood sugar? Do you think that would be appropriate? Okay, so then if her blood sugar is 18, do you think that's what maybe could have caused her to be coding right now? Okay, so that's hypoglycemia, right? So that's one of the H's and T's. So what would we give her to help while we're doing CPR? But what would we give her that would probably help improve her outcome? If her blood sugar is 18, 1 8. We would give her dextrose 30%, like in a big syringe. Like we would give her like IV sugar, right? And as we give that into her veins and continue doing CPR, I believe that there's a big chance that she'll come back. All right. What about if you're doing CPR on a patient and we're trying to figure out what went wrong, and the nurse says, well, he is a dialysis patient. He came in this morning because he's missed the last 2 weeks of dialysis. And we know that dialysis helps to remove acidic waste from the body. So, do you think that maybe he could be coding because his body is in a severe state of metabolic acidosis? So somebody said, so back to the diabetic patient, somebody said, why not glucagon? So glucagon is an IM injection. So write this down. Glucose and dextrose are the same thing. Glucose and dextrose are the same thing, but glucose is given orally. Dextrose, you give it IV. Glucagon, you give it as an IM injection. So if a patient is coding, which one do you want to use? Do you want to use oral, IV, or IM? You want to use IV. So that's why we would give dextrose 30%, or even, I'm sorry, dextrose 50% actually. It's in a big syringe and it's like a syrup and you're giving it IV. Okay. And I'm telling you, she's coming back. Okay. All right. So back to the other patient who missed dialysis all those days. Do you think that they could be coding because maybe all that acid in their body has caused severe metabolic acidosis? Do you think that could be happening? Okay, so do you think we should take the iStat machine, which you prick the patient's finger and you put a little blood in, and it's going to give you the ABG results? We have to do that, right? Because we just can't assume like, oh, it's because of dialysis. We need proof. We need the ABGs, right? So we need the ABGs to show us that the pH is down for acidosis, right? And that the bicarb is also down. Okay. Yes, my dear, you give IV dextrose for low sugar, and that will help improve the patient's blood sugar. Perfect. You've got it. Okay, so back to the dialysis patient. So let's say we do the iStat and we see that while we're coding them, we're doing CPR, everything, someone else whose hands are free got a sample of blood from the patient's finger, put it in the iStat, the ABG results come back, it is metabolic acidosis. Could that be why that patient is coding right now? Absolutely. So what are we going to give to counteract the acid? So their body's too acidic. So we're going to give sodium bicarbonate, the base, a base. And so that's going to counteract the acid. And I've seen that in all these situations. Well, okay, I'll tell you. Okay. So yes, okay, we give the sodium bicarbonate. We're continuing to code the patient and the patient probably will come back. So that's the hydrogen part of the H's. Okay. What about if they were exposed to severe cold weather and we put them in a warming blanket and in a warm environment? That also will help bring them back. That's the hypothermia one, okay? What about if it's hypoxia? For example, maybe they got like a narcotic overdose or benzodiazepine overdose. So what if while we're doing CPR, well, what if like, okay, you got report, your patient is an oncology patient, and the night shift at 5 a.m. gave the patient OxyContin, and then at 7 a.m., the patient was in pain again, so they gave them IV morphine. Okay. And the patient had a Percocet in their purse from before and took some of the Percocet. And so now you're coming in 7 a.m. to say hi to the patient. The patient's not breathing, they don't have a pulse, we're doing CPR. And as you're getting the history of what they've received, what is the antidote to reverse narcotic overdose? Naloxone, Narcan. So we give the Narcan, right? zero point 0.4 milligrams per ml. You give the Narcan. Guess what? The chances are she's coming back. Okay. What about if you're in the ED and a teenager comes, they stole their mom's anxiety medication and they took too much of a benzodiazepine, they took too much Xanax, and now they're coding. What antidote are we going to give them? Flumazenil, very, very good. Flumazenil. So, right, so as we're coding the patient, trying to bring them back, we give them what is going to help them, right? And so you're gonna laugh, but every situation I've told you is a situation where I was helping out with a patient who was coding, and we gave those treatments, and each of those patients came back to life. So, knowing the proper treatments and knowing how to handle the situation, you will save patients' lives. It works. Okay, is this a sinus rhythm? Very good. And so what is this rhythm called? Asystole. Very good. Very good. So what is the treatment for this patient? CPR. Very good. CPR. Excellent. Because you don't do defibrillation for this because there's no rhythm to defibrillate. Defibrillation, you're trying to work against a bad rhythm, like counter shock it. But here, there's nothing to shock. The heart muscle's not moving at all. So we have to move it. We have to pump it with the CPR. Good. What about if we're doing CPR on a patient, we stop for a pulse and rhythm check, we see this beautiful rhythm on the monitor, but we're checking for a pulse and the patient has no pulse. What do we call this? PEA, the liar. She's such a liar. Oh my God. PEA, Pia, she's such a liar. There's a rhythm on the monitor, but there is no pulse. So this rhythm is a lie. What you see on the monitor, you see this, but what's really going on is this. Okay, so that's why we treat them the same. PEA, the treatment is what? What's the treatment for PEA? CPR. Very, very good. All right. So if you got this EKG strip on the NCLEX, does this patient have a surgical implant of some type? And if so, what is it? They have a pacemaker. Very good. And so is this patient atrial paced or ventricular paced? Atrial paced. Why? They're atrial paced because the pacemaker spike comes before the P wave. Very good. Okay, what about this patient? Do they have a pacemaker? Okay, and are they atrial paced or ventricular paced? Ventricular, very good. And then what about this patient? Is this patient atrially paced, ventricular paced, or both? Very good. All right. So something happened here on this EKG strip. Oh, Miss Frislane, you said, okay, you want to know why is it both? Okay, so wherever you see the pacemaker spike, if it's in front of the P wave, it's atrial paced. If it's in front of the QRS, it's ventricular paced. So because the pacemaker spike is in front of both the P wave here and the QRS here, it's both atrial and ventricular pacing. Okay, so for this one here, the pacemaker, you see, you got it? Okay, perfect. Don't ever be afraid to ask a question. That's why we're here. Every day we're all, me, you, everyone, every day we're all just trying to learn, right? Every day. So don't ever be afraid to ask a question. Okay, so something happened here. I feel like there was three normal heartbeats, and then all of a sudden something strange happened. What is this rhythm? This is supraventricular tachycardia. Okay? And as you can see, we had three normal heartbeats and then a sudden onset of this very rapid rhythm. We've lost the P wave. Like, what has happened here? Okay, so there's some things I showed you that I want you to remember for NCLEX. When you think of SVT, I want you to think of your S's. So what does SVT look like? It is super what? Super skinny. Very good. So as you can see, compare it, look at the normal heartbeat right here. Compare it to the onset of SVT. You can see that it gets very skinny. So we call it narrow complex. The QRSs become very narrow complex, very thin. So I want you to think for SVT that it's super skinny, okay? And then is this a slow rhythm or is this a fast rhythm? It's super fast. Very good. Remember, it's called supraventricular tachycardia, and it is a tachycardia. Okay? You know, it's like, it's not just, oh, you're not going to see SVT like in the hundreds. Because I know that's the definition of tachycardia, right? Heart rate of 100 or greater than 100. You're not going to see like SVT 110. SVT is like 150, 180, 200. Okay? So it's super skinny, it's super fast. What is the name of the medication you give to treat it? Adenosine. It also has an S in it. So it looks super skinny, it goes super fast. You treat it with adenosine. And do you give adenosine like very slowly? Do you have to slam it quickly? What? You have to slam it very fast when you're giving it IV push. And can I give it in any vein in the body? Can I give it like in the foot or the hand? Or do I have a landmark? I can only give it in the AC or higher, right? Very good. So you're going to slam it fast in the AC or higher. Why? What's going to happen if I give it anywhere lower than the AC? The AC is on top of your elbow. Okay. All right. And it stops the heart. So do you want your patient standing up when you give them adenosine? No, they need to be laying down. Okay, very good. All right. So what are these different parts of the EKG waveform called? So what is number one called? We just learned about it for heart blocks. Okay, so on the screen here, number one, it's not pointing at the P wave. But what is the part, what do we call The portion of the EKG waveform that is before at the beginning of the P wave to the beginning of the QRS. What do we call that? And we measure that time to see how long it takes the atria to communicate with the ventricles. PR interval, very good. Ooh, okay, and then what is a normal PR interval? Time frame. 0.12 to 0.20 seconds, or 3 to 5 boxes. Very good. Number 2 is the PR segment. Don't worry about that. Number 3 is your QRS complex. Number 4, you have to know that one for NCLEX. What is this one called? Number 4. The time from when the S comes back up to the isoelectric line to before the T wave. That's the ST segment. Very good. So what's most important about the ST segment is the way it looks, right? You want it to be flat. And what is the EKG word for flat? Isoelectric. Very good. All right, very good. Okay, so a normal PR interval is how many seconds? I just said it. Point 0.12 to 0.20 seconds. So if each little box is 0.04 seconds, and if a normal PR interval is 0.12 to 0.20 seconds, then how many little boxes is it? 3 to 5. Beautiful. All right. We did this. Oh, I'm sorry. Oh, man. Okay. And we did this one like in the beginning of class, so we're not gonna like stress so much about it, but this PR interval, how many boxes is it? You should do this super quick. 3 boxes. There you go. From the beginning of the P wave to the beginning of the QRS, you got it. And that means 3 times 0.04 is 0.12 seconds, so it's normal. All right, so I want you to tell me what type of, well, first of all, is this a normal EKG that you're looking at? Well, first of all, let me ask a question. Let me like do like a real nursing question. Is this a sinus rhythm? Very, oh my gosh. Yes. If you understand that, you're good. This is a sinus rhythm, right? But what there's just one because there's a P wave in front of every QRS. The QRSs are all the same distance apart. It's just an issue here. What is the abnormality that you've seen? That the PR intervals are too long, right? Because just think, it should be just 3 to 5 boxes. And right here alone, 1, 2, 3, 4, 5. So the moment it's gone past 5 boxes for you before the QRs, it's prolonged PR interval. And so you count all of these and they're all 7.5. Let's say, because I don't have time to count. Okay, it's all 7.5. And I didn't mean to say I don't have time to count. What I meant to say is I want to keep moving at the momentum we're moving in the lesson. Okay, so let's say they're all 7.5. So what is this rhythm? So this rhythm, this is first degree AV block, and you can say that this is sinus rhythm with first degree AV block. Okay? Don't put normal because it's not normal, but it is a sinus rhythm because anytime there's a P wave in front of the QRS and the QRSs are all the same distance, but it's a it originated from the sinus node. So it is a sinus rhythm. Sinus rhythm with first degree AV block. And it's first degree because the prolonged PR intervals are all the same length, right? 1, 2, 3, 4, 5, 6, 7.5. 1, 2, 3, 4, 5, 6, 7.5. It's all 7.5 across, okay? What would you call this one? So for this one, you're going to have to count the PR interval duration. So determine the PR interval durations, and then that's going to guide you in identifying what this is. Put your answers in the chat. Okay, so this is second degree heart block, but is it type 1 or type 2? So this is second degree AV block type 1. So remember, longer, longer, longer drop, Winky Bach. Okay, so this PR interval, let's see, 1, 2, 3, 4. So that's normal because it's supposed to be 3 to 5 boxes. Then 1, 2, 3, 4, 5, 6, or 6.5. So from 4 to 6.5. Then 1, 2, 3, 4, 5, 6, 7.5. So it went 4, 6.5, 7.5, and then finally this one dropped. So longer, longer, longer drop. That is second degree AV block type 1. Okay. And then what about this one? In this one, the PR intervals are consistently long. They're the same, it's just they're too long and then it drops. That would be very good. That would be second degree AV block type 2. Okay. And finally, what is this one? I don't think this is the last rhythm, right? I think we have, but what is this one called? And what is the tip you can use on NCLEX to help you remember how to identify it? Very good. Third degree AV block. And you can remember it, count the P's and the QRSs, and you'll see there's more P's than QRSs. And sometimes you see a P wave with no QRS. You see severe prolonged PR intervals. And so, of the heart blocks, which one is considered a medical emergency? Third degree. This one is considered a medical emergency. And how do we treat it? Similar to how we treat symptomatic bradycardia, right? Atropine, transcutaneous pacing, transvenous pacing, pacemaker insertion. Okay. All right. Give me one moment. I'll be right with you, okay? All right. So, in short, this is third degree AV block. Remember, it is a medical emergency. Thank you. All right. What is the name of this rhythm? Is this sinus? Very good. Yes. And so, is this a type of VFib or VTAC? It's a type of VTAC. And is it polymorphic or monomorphic? This is polymorphic. And so, what is the name of this rhythm? Torsades de Pointe. Very good. And what is the primary treatment that we use to treat this? Magnesium, very good. So this is torsades de Pointe. It's a type of VTAC. And the problem here is that it can develop into ventricular fibrillation, and we treat it with magnesium. All right, guys, give yourselves a round of applause. You did wonderful, wonderful. I'm happy with how you guys were answering the questions. So very, very good. Make sure you review your heart blocks. So let's take a 5-minute break, and then we're going to just finish up class by beginning to talk about coronary artery disease, one of the leading causes of death in the world. Okay, you will see this on the NCLEX. You will see coronary artery disease. So you have to learn that there are different types of treatments for it. What is a modifiable versus a non-modifiable risk factor? What are the different types of angina? What is acute coronary syndrome? So there are some things that we need to review to prepare you for this, okay? So we're just going to start, talking about it this class, but we'll really get in depth next class. Thank you so much. 5-minute break so I can load up all the videos. Thank you. All right, guys. So first we're going to start with a video. We're going to watch 2 videos on coronary artery disease, and then we're going to talk about it a little bit, and then I will give you your homework so that you can come back to class prepared for further learning and discussion about it. So here's the first one.
I'm Dr. Stephen Kopetsky, a cardiologist at Mayo Clinic. In this video, we'll cover the basics of coronary artery disease. What is it? Who gets it? The symptoms, diagnosis, and treatment. Whether you're looking for answers for yourself or someone you love, we're here to give you the best information available. Coronary artery disease, also called CAD, is a condition that affects your heart. It is the most common heart disease in the United States. CAD happens when coronary arteries struggle to supply the heart with enough blood, oxygen, and nutrients. Cholesterol deposits, or plaques, are almost always to blame. These buildups narrow your arteries, decreasing blood flow to your heart. This can cause chest pain, shortness of breath, or even a heart attack. CAD typically takes a long time to develop. So often, patients don't know they have it until there's a problem. But there are ways to prevent coronary artery disease, ways to know if you're at risk, and ways to treat it. Anyone can develop CAD. It begins when fats, cholesterols, and other substances gather along the walls of your arteries. This process is called atherosclerosis, and it's typically no cause for concern. However, too much buildup can lead to a blockage, obstructing blood flow. There are a number of risk factors, common red flags that can contribute to this, and ultimately lead to coronary artery disease. First, getting older can mean more damaged and narrow arteries. Second, men are generally at a greater risk, but the risk for women increases after menopause. Existing health conditions matter too. High blood pressure can thicken your arteries, narrowing your blood flow. High cholesterol levels can increase the rate of plaque buildup. Diabetes is also associated with higher risk, as is being overweight. Your lifestyle plays a large role as well. Physical inactivity, long periods of unrelieved stress in your life, an unhealthy diet, and smoking can all increase your risk. And finally, family history. If a close relative was diagnosed at an early age with heart disease, you're at a greater risk. All these factors together can paint a picture of your risk for developing CAD. When coronary arteries become narrow, the heart doesn't get enough oxygen-rich blood. Remember, unlike most pumps, the heart has to pump its own energy supply. It's working harder with less. And you may begin to notice these signs and symptoms, a pressure or a tightness in your chest. This pain is called angina. It may feel like somebody is standing on your chest. When your heart can't pump enough blood to meet your body's needs, you might develop shortness of breath or extreme fatigue during activities. And if an artery becomes totally blocked, it leads to a heart attack. Classic signs and symptoms of a heart attack include crushing substernal chest pain, pain in your shoulders or arms, shortness of breath, and sweating. However, many heart attacks have minimal or no symptoms and are found later during routine testing. Diagnosing CAD starts by talking to your doctor. They'll be able to look at your medical history, do a physical exam, and order routine blood work. Depending on that, they may suggest one or more of the following tests: an electrocardiogram, or ECG, an echocardiogram, or sound wave test of the heart, stress tests, cardiac catheterization and angiogram, or a cardiac CT scan. Treating coronary artery disease usually means making changes to your lifestyle. This might be eating healthier foods, exercising regularly, losing excess weight, reducing stress, or quitting smoking. The good news is these changes can do a lot to improve your outlook. Living a healthier life translates to having healthier arteries. When necessary, treatment could involve drugs like aspirin, cholesterol-modifying medications, beta blockers, or certain medical procedures like angioplasty or coronary artery bypass surgery. Discovering you have coronary artery disease can be overwhelming, but be encouraged. There are things you can do to manage and live with this condition. Reducing cholesterol, lowering blood pressure, quitting tobacco, eating healthier, exercising, and managing your stress can make a world of difference. Better heart health starts by educating yourself. So don't be afraid to seek out information and ask your doctors about coronary artery disease. If you'd like to learn even more about this condition, watch our other related videos or visit mayoclinic.org. We wish you well.
When a myocardial infarction strikes, the blood supply to the cardiac muscles is suddenly restricted. Starved for oxygen, these muscles begin to die, and within minutes are unable to keep the heart beating. The cause of this life-threatening attack is the obstruction of a coronary artery by a blood clot, resulting in most cases from atherosclerosis, which in the coronary artery is called coronary artery disease, or CAD. In patients with CAD, atherosclerosis can begin to develop decades before symptoms arise. Since atherosclerotic plaques grow slowly. When a plaque ruptures and a blood clot forms, the threat of a vascular event becomes very real. Clots consist of activated platelets stabilized by fibrin strands. While activated platelets aggregate to seal the rupture site, fibrin formation is triggered by the coagulation cascade. An important part of this chain reaction involves factor Xa and prothrombin. When factor Xa encounters prothrombin, it cleaves prothrombin into thrombin. One molecule of factor Xa can catalyze the activation of 1,000 molecules of thrombin, which cleave fibrogen into fibrin. Fibrin then assembles into strands. Thrombin also leads to further platelet activation via PAR receptors located on platelets, thereby increasing platelet aggregation. This activation doesn't only happen in the blood flow, but occurs predominantly on the plaque surface. Because of thrombin's effects on platelets and fibrin, it offers a specific therapeutic target for the inhibition of arterial clot formation. Vascular protection through reduction of thrombin generation is a promising approach currently under investigation for the prevention of myocardial infarction, stroke, or cardiovascular death in patients with CAD.
More than 6% of adults suffer from ischemic heart disease, which results from coronary artery disease, or CAD. Ischemic heart disease is the most common single cause of death worldwide. Atherosclerosis is a systemic disease characterized by the formation of plaques in the arteries. Depending on the arteries affected, this can lead to stroke, myocardial infarction, or acute limb ischemia. Atherosclerotic plaque formation in the coronary arteries is characteristic of CAD, a progressive condition that causes restricted blood flow to the heart. Rupture of one of these plaques can lead to the formation of a blood clot in the lumen of the artery, known as atherothrombosis. This blood clot can grow to further limit or even completely block blood flow through the artery, potentially resulting in myocardial infarction. The degree of stenosis, or narrowing of the arteries, and characteristics of the plaque determine the symptoms that a patient may experience. There may be no symptoms until significant stenosis has occurred. Apart from event prevention through lifestyle modifications, such as smoking cessation and dietary changes, guidelines for the treatment of CAD recommend risk factor management for hypertension, diabetes or dyslipidemia, antithrombotic therapy with antiplatelet agents, and in some cases revascularization, using a stent to widen the artery and restore blood flow. Despite antiplatelet therapy, the residual risk of atherothrombotic events remains high. In one clinical study, there was a 7% residual risk of stroke, myocardial infarction, or cardiovascular death despite dual antiplatelet treatment in patients with or at high risk of cardiovascular disease. In another clinical study, dual antiplatelet therapy with ticagrelor and acetylsalicylic acid in patients with previous myocardial infarction reduced the risk of adverse cardiovascular events but increased the risk of bleeding. Despite this, 8% of patients still experienced adverse cardiovascular events over 3 years. To help reduce this residual risk, clinical trials are investigating optimal treatment strategies in patients with CAD. The results of these studies hold great interest for physicians and patients alike.
All right. So that was just a short preview of what we're going to start talking about next class, which is we're going to begin talking about coronary artery disease and understanding why the formation of atherosclerotic plaques on the inner lining of the coronary arteries, we're going to learn how it reduces the lumen size. And so therefore it's very easy for the plaques to rupture, and it can cause blood clots to form, and it's also very easy for it to cause heart attack and stroke and death. We're going to learn about the type of patients who are more vulnerable to this. And we're going to learn about the lifestyle habits that are associated with this. So this doesn't happen overnight. The formation of coronary artery disease and fatty plaques in the inner lining of the arteries does not happen in a week, in 2 months. It happens over years and years of poor diet, lack of exercise, smoking. Okay, and poor diet is probably the #1 factor. Eating lots of fried foods, greasy foods, fast foods, from McDonald's and Burger King and KFC and Grill and Accra and Marinade and you know, just any kind of fried foods. These are what contribute to this. And when we talk about years and years of high salt in the diet, salty foods increase the blood pressure and make the heart work harder. In combination with coronary artery disease, it can lead to cardiac death. So we're going to learn about that next class, and we're going to learn about the different types of angina. We're going to talk about the medications used to treat them, and then we're going to talk about the treatment algorithm. We're going to talk about what is a CABG. We're going to talk about what is a percutaneous intervention. We're going to learn about what is a cardiac cath. So we have a lot to learn. So my best advice to you at this point is 2 things. #1, make sure that you are very strong in your EKG rhythms. But from what I saw on the quiz today, you guys are pretty much there. I was very impressed with how you did on the quiz. Very good. So if you're strong with that, if you understand everything we went over in the quiz, you will be good no matter how they attack you with the questions on NCLEX with the EKG rhythms. I believe you will get them correct. So just make sure you're strong in that, and then you can read ahead in your book for coronary artery disease, and that's what we're going to start with. All right, guys, thank you so much for a wonderful class. I will send out the recording the moment that it's finished. God bless you. Remember, you will pass the NCLEX. You're going to make it. You will make it. Nothing is going to stop you. God bless you. See you next week. Thank you.